All right, so let's go to the next topic, embolization of any abnormal vessel versus only the painful side. Oz, you have any abnormal vessel. Sid, you have only the painful side. Oz, you want to start?
Sure. Yeah. I mean, I think there's obviously the Landers paper that suggests that the more you do, the better the patient does. I think, if you probably survey most of quote unquote experts in the MSK field, including Kuno himself, they will basically target any vessel that shows abnormal hyperemic blush. And I think probably, at least in my own practice, I have found more often than not, even if you go to the quote unquote other side, you'll see some anastomotic collateral network that then communicates to that side of the pain. I think especially in the era of temporary resorbable embolics, where sort of the embolic is more forgiving, it's probably better to sort of commit an error of commission as opposed to omission.
I don't necessarily, it's hard for me to disagree because I would argue that we don't really know yet. I'm on the fence with this one. I really am, because as Oz mentioned, the Landers paper, so Landers did this randomized trial, which was negative, and even in his own discussion said, we didn't embolize a lot of vessels. So and when we did in a subgroup analysis, then we did have better results. So maybe the argument is that you need to embolize more vessels. So how many do you embolize? Do you embolize 6, 8? Like, do you start going superior patellar and recurrent ascending tibial and all the other geniculars? So I don't know what the limit is. I do agree that just doing one may be inadequate in many. I just don't know where that midpoint is as to not too many. It's like the mama bear, right? Like, it's not too hot, not too cold kind of thing. I think we're going to figure this out eventually. This is going to be easier to figure out than the MRI question that you alluded to earlier. I just don't know what the right answer is. I do think embolizing more than one is probably favorable. So for example, if you have medial knee pain and you see the descending genicular artery lighting the medial side of the knee, yes, you should embolize it, but you should at the very least examine your other medial branches. Whether you examine your lateral ones, I tend not to. That being said, I do a cone beam CT, and if I see it wrapping around the patella, then I will. I don't know if we have a right answer here.
Okay, so let's phrase this question a little bit differently. Let's say you don't have access to resorbables. How about then?
So I don't have access to resorbables. I can talk about Lapiodol, which we do have access to, but we're not using that for genicular artery embolization. So we are using permanent. I think many centers, if not most, in the United States are using permanent. We have had all of our results, including our published results, using permanent. There is a randomized trial, which has not yet been published, but was presented out of Brazil, where they showed pretty much equivalent results with permanent and resorbable, maybe hedging towards permanent in terms of efficacy, but not statistically significant. That being said, I think the safety profile for resorbables is superior. I have no doubt that it is safer. I was going to say you have to be more careful using permanent. I would argue you should be careful using both, right? The resorbable does give you a little bit more, I guess, room for error, is the best way to put it.
I certainly agree with that. I think if you are using permanents, which probably the majority in America are, definitely, and that's what I use sort of in the first half of my GAE sort of experience, definitely less is more, whether it's the amount per vessel, the number of vessels you're doing. I think you still need to be very sort of much more confident that you are sort of selectively embolizing a vessel that you believe is a source of pain. I think the approach with a temporary, like an imipenem or a Lapiodol, is much different in the sense that, your threshold is reduced much lower, I think. I kind of go into vessel and say, it looks kind of abnormal. I'm going to just take this out because I know that the Lapiodol is going to wash away in like 10 minutes. And I don't really, there's really, arguably very little side effects related to it. So, but I'm with you, Sid. I mean, we don't know. There's a lot of unanswered questions. One of the unanswered clearly is how many do we embolize? I think the data is trending towards more is better. I think there is that one paper that just came out saying that even in severe OA, as long as you embolize 3 vessels, it seems like you're getting, decent results. I have another question for you, Sid, maybe that is on this line is, let's say you did do that DGA, right? And you clearly see anastomotic communications with the inferior medial, superior medial, and you see your particles or whatever you're injecting, sort of going into those vessels. Would you go into those other vessels and still embolize them?
I might consider going into the other vessels and just doing a diagnostic angiogram. And if there is antegrade flow and hypervascularity and neovascularity, then I would. And if there isn't, I would not. So in most cases, when I do see that anastomotic communication, let's say I'm in the descending after the embolization, I see that anastomosis, and then I go ahead and catheterize, let's say, the superior medial. In almost every case, what you'll see is just communication back to your descending, but not to any area of hyperemia because that's been treated already. And so then I just look and I don't embolize.
Yeah, I agree. That's almost to a T what I do. I guess maybe where I have an issue is, what if you can't get in the vessel, or like it's a tiny vessel, it's hard to get into? Do you lower your threshold to abandon going into it?
Yeah, I might. I agree. I think I do lower it. That being said, this is cheating a little bit. Pretty much all of our patients are on trial, so we don't give up.
Yeah.
We don't want to. I know this is not fair, but on a clinical trial, you don't want to have technical failures, right?
Yeah.
So we make sure that we are technically successful in all our targets in terms of catheterizing and doing angiography.
Okay. I like it.